Healthcare afternoon, and we're pivoting now to today in the State House. Excuse me, it was Intellectual and Developmental Disabilities Advocacy Day. And we are joined today by members of Washington County Mental Health to tell us about the great work that they do in this regard. So welcome.
Thank you. Thank you. Just get rolling?
Yeah.
Okay. For the record, Beth Seitler, CEO, Washington County Mental Health Services. I'm here with
Megan Paul, the Developmental Services Director.
I did a similar presentation to some of you folks last year, kind of tuned it up with some new information. So the idea here is to give you an idea of the intersection between mental health, developmental disabilities, because they, while they're overseen by different systems, they really interact a lot. And I'm recently started at a designated agency, and I see this a little bit more now. So just in terms of scale, our mental health system is about half of the full kind of system of care, developmental disabilities, the other half, and almost half of the people in developmental disabilities also have a mental health co-occurring diagnosis. So about 75% of people in our service system are affected by mental health. The services so I started in the system 30 years ago or so at Howard Center. I've done a tour of Howard Center, Champlain Community Services, and now Washington County. And when I first started, there was a lot of siloing of, if you were working with somebody who had a developmental disability, you couldn't necessarily even get supports from the other side of the house, that it wasn't really integrated. And there was this assumption that people with intellectual disabilities or IDD needed some sort of special services. And what we've tried to push back on is the understanding that people in services are just people, and they need care, and they need mental health care like any other kind of care. Just as a point of reference, because I know you tend to work in the mental health realm, mental health and DD are both going through finance reform, or full system reform in terms of developmental disabilities. And conveniently, they took separate tax. So they're both doing things a little differently. We'll see a little bit about how that's affecting them. So you're probably familiar with the changeover in CRT, maybe you're not, with the funding stream changing and moving out of HCBS funding. Well, developmental disability is staying with HCBS funding, which means that we had to instead pull conflict of interest out and case management out of the system. This starts in
October 1st.
October 1st. We've kicked it down the road a couple of times, but it's time for us to finally do it. So when we're looking at mental health, we're looking at the complexity of the person and services. And in 2018, I think it was, we looked at, we were trying to, I'm sure it was a point of advocacy for us. We were trying to figure out, how do we demonstrate to you the complexity of the people in services? And we were trying to think, like, what shows this? One of them was the mental health needs of people, substance use disorder, which is often surprising to people that people in developmental disabilities have substance use disorders, but it's true. Complex health issues, history of trauma and abuse. I think this is around the time there was the National Public Radio article about abuse with people with intellectual disabilities, and it demonstrates something like 10%. I would say, I don't know what you would say, that it's higher than that. It's much, much higher than that for the people who are in services with us. And then a risk or history of homelessness, which of course you're hearing a lot about. So we convened this survey, which was pretty simple, really just asking service coordinators or care providers, does the person who you work with have one of these 5 issues, yes or no? And, can this give us an idea of the complexity of the people who we're serving in the system? Here's the last 2 that we did. And as we've refined this over the years, it used to be sort of looking at the person throughout the entire year. We've tried to define this for looking at the person in October. I don't know why we chose October. Anyone know? So we wanted to, probably a 31-day month to look at, whether this individual was needed support in this way. So this gives you an idea of how this breaks out. Like I said, about 50% of people have co-occurring mental health disorders. Substance use, 3%, 4%. I would say that's about the same for what we see at Washington County. Significant health, chronic conditions, 34%. These would tend to be people who would be in residential services, shared living providers, maybe in group homes. History of trauma. This is what's known. You know, we don't always know everyone's trauma or abuse history. And then homelessness is something that we've been looking at, like everybody in Vermont. So as we were using this as a point of advocacy, we also wanted to look at how many people are in crisis. And again, this was looking in October. We did this for several years. I'm sure we'll be doing it again this October. And the way that we determined this is whether or not the person was in crisis. And then on the next slide, you'll see whether or not they were hospitalized as a result of that. Another thing that healthcare is looking at, obviously a lot, is whether or not we have people who are going into the hospital. Oh, I should have asked, how long do we have now?
As long as you would like. You are our last guest today. Daisy's about to put her hand up to say she needs to. Go ahead, Daisy.
No, I'm happy to stay here for dinner with you all and just keep going. It's a beautiful flight. Yeah, I'm thinking time. No, I was gonna say October 1, maybe because it's is it tied to a federal grant? That's the start of the federal fiscal year.
I don't know if we're that thoughtful in it.
That was gonna be my next question. Is all this survey tied to a federal?
It's not, no, it's just really homegrown. We really just kind of came up with a way to show the complexity of the people in services. Sometimes I describe people in developmental disability services as being like I think you'll get this reference, the Ginger Rogers of the service system, who are dancing backwards in high heels. I mean, the incredible complexity that people have coming into services is seen. And we wanted some way to be able to show this and say, this is really what's happened. And for some reason, numbers do that pretty well. So we got a little bit more sophisticated in this process. We drilled into what we really needed. We convened a work group, as you do when you want to look at something a little more. And this work group came together and improved the complexity of care survey. Also looked at overall DS crisis support. And it really began to shed a light on people in services. And I can't remember what slide we're on.
This is the next.
All right. We'll get to it. So one of the other things that comes to mind as people are asking about mental health needs of people in our service system, the acuity of people in our service system, there's an increase that we've seen. Certainly I've seen that, and there's a lot of questions. What's happening? Why are these diagnoses increasing? Why is there more depression? Why is there more autism diagnoses? And we don't know for sure. We know there are a lot of different reasons that could be contributing to this. One thing, kind of an easy thing, is a change in entrance criteria, the evaluation process. So I won't go too far into this, but the process by which people come into developmental services is there's an assessment, there's a eligibility for Medicaid eligibility, there's an assessment, and then there's a demonstration of need. And those windows over the years have become smaller as you go through each one. And that has meant that the people coming into services have higher acuity and have higher needs. The other thing is that people in our service system are doing well. They're well served by us. They're living longer, and their needs are getting more intense as time goes on. The other considerations, we had a pandemic. We had some continued stresses around staffing, which has impacted this part of our service system more than other parts of the service system. Developmental disabilities, turnover rates, and vacancy rates are higher typically than the other side of our system. Measuring acuity is challenging, of course, and now, let's see, ED visits are another way that we're looking at
The data shows in the month of October, just the number of ED visits. But what's challenging with the ED visits, with people with intellectual disabilities or autism, when they get to the ED, sometimes their mental health crisis is defined as behavioral. And sometimes they're discharged very, very quickly, and they don't get the help that they need. There's a technical term called diagnostic overshadowing, and it's where a clinician or a professional looks at one diagnosis particularly and defines that this diagnosis is kind of more important than the others. But we found out in DS that people get dysregulated all the time and need mental health treatment. But because of the diagnosis, they are deemed that they're having behavior and they're released. And sometimes that doesn't work because this person is having a mental health crisis, and the best way to deal with it is for them to get that level of intervention at the hospital. So they go back into the community, and sometimes it takes 2 or 3 visits or 4 visits before they actually get the help they need. Resources.
Daisy, did you have a?
Yeah, on the previous slide, when you said for I just want to be sure that I understand what you mean by behavioral. Visits for behavioral or mental health symptoms. Do you mean substance use and mental health when you say behavioral?
Yeah, they all can be lumped in, yes. So behavioral and mental health. So yes, substance abuse, that will tie into that.
Okay.
So sometimes, somebody can be, give you an example, somebody could be in withdrawal, and they may, that withdrawal may cause them to have some slight symptoms of seeing things or feeling increased anxiety or feeling violent, and that constitutes a mental health issue or behavioral issue, so they can be seen that.
Thank you.
To just add something to that, one of the other problems I think that that people encounter is that often their mental health issues are described as behavior as well, that they're sort of acting this way to gain something, or that it's operational as opposed to just mental health.
So resources, medical directors, psychiatrists, experienced staff, inpatient care. We're experienced in Washington. We have an open medical director position. It's not easy to fill. The trained staff, clinicians, just experienced staff overall, they're hard to recruit and they're hard to bring to Vermont. So as a system, we see that as a resource that we need to kind of increase. Network crisis beds, I think there's 6 total in the state of Vermont. They're not always available. Got some good news earlier in the hallway that 2 beds may be open here in a couple of weeks, but that's a surprise because they're hardly ever open year round. So in my personal experience trying to place people in crisis beds or residential short-term placements throughout the whole state, when they're having mental health issues in developmental services, once you reach out and you send the packet of information that the provider needs, once they see the developmental services, they say, oh, we can't help you. So oftentimes we look out of state. Those are few and far between. And sometimes we just have to create a crisis bed without the trained staff that we really, so increasing the network would be nice. And just having a place where people can land and get the services that they need and don't have to leave their natural environment.
I'm sorry, can you, how many beds do we have in the state for, this is with residential treatment for someone with a co-occurring mental health and IDD? 6?
There's 3,058 people in the service system. Probably, about residential services. But it wouldn't be just so many residential services who would be in a crisis. It could be anybody.
Yeah.
Who would be eligible to go. So yes, 6.
When the incidence of co-occurring disorder is almost 50%.
Yes. Yeah, it's tremendously under-resourced. And as you can imagine, I mean, hearing that there are 2 beds open, it's something that never happens. Typically it's a 3-month waiting period. And so we have a homegrown couple of crisis beds at our organization. Others do too, and they're usually filled, or we share them with each other. So the state has 4 of those beds, 3 adults, 1 for children, and then Gloria has collaborative.
To under collaborative risks. She also shares.
So it's not enough. And I mean, this is something that we have, we've tried to push back on as much as possible. It's expensive, you know. The bricks and mortar part, you can't use Medicaid dollars to build, you know, so it's trying to figure out the resources to build the buildings. And then upkeep also isn't supported.
But right now, I think our options that these SSAs have been using is trying to convince the medical staff at hospitals to recommend a Brattleboro retreat stay. And that could last a week or two, but it's not long enough to get the person through the crisis that they're experiencing. So sometimes that's the option, the mobile crisis, inviting the CIN to come in and do mobile crisis and have staffing for a period of time. Those are options, but those are not exactly what we call therapeutic in nature for somebody going through a mental health crisis. Agency on call, trying to increase that capacity. For Washington County, we got down to 3 responders. When I first started back in 2022, we had 7 responders and about 8 admin. We got down to where we had 3 responders and 2 admin staff. Just keeping staff consistent from burnout is almost impossible, but increasing the capacity for our agency crisis teams and getting staff trained in an appropriate amount of time so they can contribute to those teams. And then support from Dell for clinical trainings and evaluations. A lot of that is left up to the DA, and assuming that we have the funds and the time to incorporate those. And sometimes with overtime and the amount of contract staff, there's not really money left for us to go outsource professionals that we need to come in a crisis situation or just in a situation period to increase our knowledge in our service delivery base for our current staff members.
We have 700 staff at Washington County, and I think we have 100 openings right now, which it's been over 100 for a year, at least for a year. It used to be the average of 40 or 50, but it's been over 100. And so so we're trying to figure out contracted staff. And as a designated agency, you probably know this, we don't have an option whether or not to serve somebody. If someone's in our catchment area, then we're determined and obligated to serve them.
Albert, did you have a question?
Yeah, in terms of the problems that you have presently with staff, the stuff that you're putting up on the board, how much of this is operating at a level that would be considered appropriate?
Very little, I would say, unfortunately. We have situations where I'm thinking about situation we've been dealing with recently where we had, let's say 9 staff, and I think 7 were contracted. And if they're coming in for a few months, you're not able to train them up. And these are incredibly complicated people. I won't go into details, but operationally dangerous and, intentionally trying to harm people to get, to make themselves comfortable and make sure they feel safe. But we are, working at a 3-on-1 model for somebody, which is a really unfortunate way to serve somebody. But to serve them with people who don't have the skills or the training or the commitment or the history with the work that we're doing, it's a tremendous disservice to the people in services and to their families. And, and we feel like on our side of the equation, we're doing everything we can to retain our staff, to recruit our staff, given, the funding level that we're in. But we'll really look at, I heard recently, maybe not so recently, it might have been last year, somebody say, well, it's not just money. And it's not just money. We know this. We're good at this. We know how to take care of our staff. We understand. Most of us have worked in this field for a long time. I started doing direct service. I worked on the crisis team. I was a case manager. Like this is our lives, and we know how important it is to have staff who are well supported and well cared for. but it also is money. It really is. I mean, you know, it's a little cheeky, but we're not trading in indigo and shell beads now. We're really, people need to live. They need to have a sustainable income. And if we can't do that, we can't keep them. And people become even more dysregulated. You queued me right up for that.
Yeah.
It's scary for people in services. We have a lot of people around the state who are in very critical condition, which, you know, as we've gone through, are not entirely safe.
Yeah, thank you for sharing that.
It's a really good question, Representative McFarland. I think everyone's been around when institutions close down, no matter what part of the state they've been in or what part of the United States. But bringing in institutional service delivery into a residential home is very, very tough because we know adding bodies is not it's not the absolute solution, nor is it the preference. When somebody prefers to be served one-on-one, now you're putting 2 people in there or 3 people in there, and that's the level of services to go to your question that we find sometimes that are not appropriate, and that we want to stay away from. But as a result of not having the resources, that's the model that we have to go to for a short time, and we try to pull it back as soon as the person resembles some form of stability. So, very good question.
There was a lot of discussion last year and the year before about a forensic unit, and it's a really important discussion, and I know it's provocative and it's controversial. And we know there's a really difficult history of people with intellectual disabilities and mental health issues being hospitalized and not cared for safely. And there's, you know, there's very good reason to look at that. On the other hand, one of the things that we worry about is are people getting the clinical care that they need, you know, as a human being, as a person who may have severe or acute significant mental health needs, are they getting that attended to? And I'm not sure that we're there yet, that we have a service system or even a healthcare system that fully understands the group of people that we're talking about and understands that they have needs, they have mental health needs that need to be served. And it's very difficult to find the right conditions for some people. A very small group of people, it's hard to find a way to serve them.
We've got touched about the financial reform and funding model monitoring. As DAs, I want to speak largely for our system, is making sure that we have the ability to come back to the table and that we have a voice as funding models change and as they develop, that we can come back and say, hey, this is not working for us. And we have a voice for people to hear that. Concern over conflict-free case management and affecting rates. We're trying to decouple financial reform from conflict-free. However, there's some aspects of conflict-free, like determining eligibility and funding, that's going to start October 1st. So even if you decouple it and separate it from starting at the same time, we still may have some issues as far as rates and how we manage them, and how we reconsider if the funds are not appropriate. Issue of IDD individuals in acute care facilities is grim. We spoke at length about the need for a forensic unit. We spoke at length about mental health short stays for individuals that are in crisis. Right now, other than Brattleboro Retreat and the VCI in crisis bed, our options are very, very limited. But just finding a place where they can land and they can get the help that they need and get discharged and try to reacclimate themselves into their normal way of life. People in Vermont with IDD are served in the community, not institutions, HCBS funding. We want to get HCBS funding a little bit earlier. But our model primarily, as you guys know, is shared living. We serve over 65% of our population in people's homes, just like you and I. They are allowed to live there. They're part of the community. They're not segregated or institutionalized in any way. But we have an aging population, and we can't ignore that. And we know people are facing trauma when their home provider passes away and they have to move and transition to somewhere else. These are all issues that we face. And we have a capacity issue, and we're worried about who does it when people are done. That's a real concern for all the service providers. Again, challenges, trained staff, housing, access to a clinician, very high acuity housing. People in the DS population do face discrimination for housing because of income. They get very limited income. Social Security is a finite fixed cost. And most people that have housing options, they want people to make 3 or 4 times the amount that now folks do not make that. So housing is going to continue to be a challenge for us. Access to clinicians, getting people to Vermont, skilled, licensed, trained, experienced people, getting them to Vermont is a challenge. Agencies work closely with the state, hospitals, and law enforcement. We had a challenging meeting this week with law enforcement. They don't want to be a taxi service, and we agreed. They don't want to give people a ride to the hospital. That in the hospital, when they get there, they're only there for 15 minutes on ice cream and they get discharged. And we understand. And they don't want to go hands-on until we go hands-on. And that's a Vermont value that I'm pretty sure a lot of people are against. And that's something that we need to revisit to see. Is it staffing? Is it training? Is it training for law enforcement and getting more communication out there so relationships are not strained? Closure of inpatient facility impacts people in DS. That was a resource. Now it's I think the word non-existent is coming to mind. Workforce challenges, Kate. I think you echoed it perfectly. It's not always about money, but money does help. I think sometimes we do things by the natural average, but we have to consider Vermont as a different place. I'm from Florida and Alabama. I lived in Alabama for 16 years. Vermont is very different from everywhere I've ever been and everywhere I've lived. It's a very nice place to live if it's for you. So we need to attract people to come here. We need to attract people to stay here. We need to find a way to retain our youth to kind of transition into positions that become open.
Sort of veered off mental health a little bit, but there's so much happening, it all intersects.
I actually had a question about that. I mean, we tend to, in this committee, we tend to concentrate on, the mental health aspect of our system of care. And then down the hall, they tend to concentrate on that. And we forget that it's one really integrated system. And I'm wondering if you have challenges because, not only is it committees in the legislature, but it's also different departments within state government. And I'm wondering if there are challenges in having to deal with, DMH on one hand, Dale on the other. DEVA, of course, is in between because they've got all the money. And, if that's a challenge for you, for our designated agencies as well.
That just makes it fun.
They call it a challenge, not fun.
So one of the benefits that we have is being part of VCP and having a network, which really helps us to collaborate. I mean, it's an incredible trade organization. We work really closely with each other. I think we understand. And yeah, it's hard when one side of the system goes one direction and the other goes the other. And you do sort of joke around like, maybe down at the Waterbury office, you could like go and, yell over the cubicle and say, how are you doing this? Maybe we could do it the same way. But there are good reasons why people do the things they do, but it can be really confusing and hard to keep it straight. I was just in a meeting this afternoon about electronic health records. We're part of 4 organizations that we collaborate on electronic health records. And so anytime something's changed in the system, it has to change with everyone and everyone has to agree. And of course that's impossible. But we were talking about building service plans and how you build a service plan when you're pulling in different parts of the organization because they're different. You need to track it. You need to be able to show that you're spending this money and you're tracking it the right way, but you want to deliver whole person care of the person in services. But you also, and you want to build a plan that serves them, but you're pulling from different places. And so how do you even pick and tie that to the service plan, to the electronic health records? And we don't know. We didn't come up with a solution. We're going to go on a retreat next week and talk about that, among other things. But yeah, it can be a little hard to figure out what goes where. And when I was working at CCS, we were looking for a psychiatrist, as most organizations end up doing at some point during the year, and approached the local FQHC to see if we could subcontract with them, and started conversations with them. And their medical director had not had felt that he had not worked with people with intellectual disabilities before, felt that it was something that was sort of beyond his skill. And so we had him come on down and, get to know people. And within, a week, he was like, this is the same work. This is just caring for people with mental health needs and, trying to figure out what their needs are. And he said, and the benefit is that they're, tend to take their medications as prescribed. So, he was also sort of thrilled to be able to work with that. Yeah. Yeah. It's hard. I mean, I
think I failed to mention that when somebody diagnosed with developmental disability or autism, when they need to be served on the other side of the house, the mental health side, funding becomes a problem, because the DS funding is very fixed, and this is what it is. Where mental health, if they go into a crisis, they can have funding for X amount of time to go somewhere. And DS is not like that. So crossing the line into the other side of the hall is an issue right now that we're facing. And we're trying to get people help with. Because somebody with a developmental disability or autism that diagnosis may not be what affects their life the most. Their mental health diagnosis may be the most prevalent thing in their life, and that needs the primary treatment.
The discussion around CCBHC, I'm sure you've heard about. Developmental disabilities is not part of that. So that's another thing for me that I'm really looking at, is how, as we're trying to integrate our organizations, we're trying to have clinical oversight for the whole organization. How do we make sure that DS is part of that? And with the funding mechanism potentially changing, I mean, who knows what's going to happen, right? So let's pretend that things are going to go forward. How will we keep developmental services as a part of the full system?
Beth, I'd love to follow up with you on that.
Some other time, okay.
Yeah. Sorry.
Okay. Yeah.
I have
Yeah.
a question. We know that the designated agencies are having problems with staffing and so on. We know all that stuff. You people live it every day. And I just want to bring us back several years when the Brandon Training School closed. There was a promise that was made that day that the services provided would now be provided in the community. You people ended up, all the designated agencies ended up as the agency that was going to actually do that. Now, many years later, this problem is huge now. You have people that are aging out. They can't take care of their children that are now adults. As a group of agencies, what have you done to put the pressure on the right places to try to solve this problem? Because this problem that we talked about today a bit has been there for a while. I know you've asked for more money and we've given you some, but not enough. This is a huge problem right now, and it's only going to get bigger.
Yeah.
So I'm just trying to figure out what you people are doing as a group. We have advocates in this building all the time.
Yeah, I would love to tell you that we have a concrete plan, that we know exactly we do know what needs to happen. I mean, there's just one problem we have, and it's essentially, we have a very strong advocate each one of us come down here and educate people as much as you can hear it, because I know this is the theme. You come in here and this is what you're coming in and hearing people say you need money and you're having to make difficult decisions. It's hard to know how to demonstrate the importance of what's really happening and what feels like a slow motion catastrophe taking place in the service system, that we have thousands of incredibly committed people trying to prevent happening. And, we've never felt closer to that. And I don't know how, I don't know if, and I don't mean this to sound disrespectful of anyone here, anyone working in the system, but I don't know if people care anymore. And I think that there's a rawness that I encounter. There's a fatigue with hearing about this anymore. And I get it. I mean, I get tired of it too. And I don't know if it's more in our service system, if that's like a special bias or bigotry. But if there's definitely sort of what I sense a quiet walking away from this problem, because there are so many other problems. I understand it, but I don't know how to bridge that anymore. We'll keep doing the same thing. I mean, at some point the system breaks, and I don't know when that happens. I hope it doesn't. We have strong people who are gonna, throw people over their shoulders and support them and do whatever they can. But I don't have a good answer for you.
Actually, no. I know personally a lot of these people, and more and more of them, over the next 10 years, they are not going to be able to, the system is going to implode because we're not taking care of it the way we should. I know some people can say that about housing and everything else. There's a limited amount of money, and we're trying to spread it out the best way we can. But I'm personally, I've been around this building for over 20 years. And I've seen this for every single year that I've been here. The problem's getting worse and worse and worse. And I'm taking responsibility of that. I personally are getting involved with families that are having problems, see if I can get them through the system. I don't know what to do either. It's getting worse, and it's going to get worse. It's going to get worse than it is now.
We have some tough weeks ahead of us, I think.
Mhm.
We have some tough weeks ahead of us too.
Yeah.
Daisy and then Brian.
Thank you both for taking the time to be here today. And I absolutely care about the work you're doing from the bottom of my heart. You're caring for many of our family members. And I just want to say that I think if any of us is not willing to admit that the system has already broken, we're in trouble. I think it has broken. I think anytime that we are receiving budget proposals in this body that defund the DAs, it's broken. But we're not going to stop fighting to fix that.
So I wasn't in the room, but I was like watching on YouTube. But I still may have missed something. So I just want to put that out there. So if you're like, I said this like 10 slides ago or whatever, then I'm sorry. But like, because people do interrupt me when I'm not here and on YouTube. But I say that because before the designated agencies existed, there was a series of sort of policies that government had for helping people with, mental health issues, developmental disabilities, intellectual disabilities. Before there were these huge institutions, like my understanding was there were like farms people would live on. I'm curious, what worked from the past that would be okay today? Like obviously, in my opinion, asylums, no.
Mhm.
Like 1,000 people in a warehouse, no. But, could we perhaps reconsider like really old ways of dealing with things, like community run farms where people could live and volunteer, and it's sort of like, and so not it's like deinstitutionalizing, but in a good way. Because what I will say is like we feed people in Burlington 3 nights a week through the People's Kitchen, and 90%, I would say 70-90% of the people have some kind of disability. And there's people with intellectual and developmental disabilities living outside, just completely abandoned. And it's like really upsetting because they are greater targets because of that. Like their stuff is taken constantly. And I won't even tell you some of the things because it's like disturbing, like how people victimize people. So like we have to do something that has to stop, but it's like there's nowhere, like even the city doesn't have a safe place, like not even a piece of land where people can just go and be protected. So I guess what I'm asking is like, what are some of the things we might be able to go back to that weren't as expensive as what Medicaid has allowed us to build? Because if we lose that and we can't fund the current structure, could we perhaps reconfigure it and at least create a new safety net or something? And then the other thing I wanted to ask is if it might be possible if any of the other advocates could have a chance to talk, because I know one young person who's here who would love to say something. So,
More than happy
Okay,
to.
okay.
Let's let them answer.
All right, yeah. I also want to make sure
Because
this.
It's a great question.
I'm so glad you said that too, though. Thank you. So I have a thought, like to say, so little story. There was a coffee shop that started in Burlington. I think it was called Perky.
Oh, yeah.
Perky
Yeah.
Planet. And so where I worked before, we about supported employment and were pretty critical of any kind of congregate work setting because we wanted people to be working independently and learning, to do things on their own, to have gainful employment. And so when that opened, there were a lot of people contacting me and saying, "Hey, Beth, do you see this Perky? Look at this." And I was like, "Oh no, like what have we done? We haven't taught the community to do this. We haven't, people are not invested in this." And I was talking to my friend Brian, who works up at the university, the Center of Disability Inclusion. And he said, "Beth, we're not there yet. You have this like philosophical perspective about what should be happening and how people should be supported. But the truth is the community is not there yet. And if you have people contacting you, celebrating this, happy that there are people with IDD working in the community, that's where we are. And that's where we start working." I don't ever want to go back to sending people to the poor farm or institutions, obviously. One thing I've learned, though, over the last couple of years is that there is a call for people who are in services to be around their peers, to be able to live with their peers. And I was not listening to that carefully for a while. I felt like we know better, which is just arrogant and wrong. And so there is a place where we need to listen to the people. And we need to be really careful not to warehouse folks. Obviously, that's not what you're suggesting.
Yeah.
I think this is what we call a mixed bag. We have places now that resemble a farm or Camp Hill model is what we call. Harpy is one of them in Vermont, but they're under a lot of scrutiny right now from Medicaid because Medicaid has so many regulations that want things done a certain way. And there's also a community in New Hampshire called Plowshare that we.
What's it called? Plowshare?
In New Hampshire that we actually sent somebody that in services there and they transitioned back to Vermont, which was a great experience for them. Lived on a farm, there was volunteers, a lot of things that you listed, but it's a mixed bag. There's some people that don't want to see those communities thrive. And Plowshare is an example of one that opted out of taking Medicaid dollars because there are so many regulations and so many things to go through. So to answer your question, I think there are, Catherine just started a service out here. I forgot the name of it.
River Flow.
River Flow. There are attempts to try to
River Flow Community.
Okay, thanks. I'm writing this down so we can look into it.
So there are attempts for people to try to go that way, but there are significant hurdles to go through to get the Medicaid dollars. So there are programs that do the Camp Hill model, but they stay away from federal funding.
So what I'm hearing is examples of people who have done it without Medicaid that we can look at if we lose Medicaid.
Plowshare is one.
Okay.
I know that a couple committee members might have like a meeting, but I just wanted to really quickly go around the room if anybody wanted to introduce themselves and if there was anything they wanted to say.
I'm Eva. I'm from Burlington and I came here today because I myself have a disability. It's a rare disability called Williams syndrome. And I have personally faced extremely bad mental health problems. that feed off of my Williams syndrome. They kind of go hand in hand. And I would say that for me, the most important thing is that whenever somebody leaves who is a part of an agency that I am a part of, that other people are a part of, it's really traumatizing. Because it's like, I'm losing somebody that cares about me. And this has happened probably 1,000 times throughout my lifetime, is that there have been people who've come, people who come and go, and it just, I think the real important thing is to have some sort of, like, you guys were talking about the fast, overturn of when people leave, and I think the important thing is to have somebody there who helps the staff. Like, that will get them to stay. If there's somebody that can listen to the staff members and be like, I had this client who did X, Y, and Z. And that might help,
Yeah, like peer training.
Yeah, or like a peer counselor. A peer counselor would be a great thing. And I also think for me in my personal life, like, it's really hard to exist. To get up day to day. Every day I struggle to get up out of my bed. Knowing that there are people out there who don't see me as like somebody who has worries. And it's traumatizing as a child when you're first born. It's a trauma to be disabled. And I wish people would understand that more.
Thank
And I could say more, but I know you guys.
Thank you.
Have places to be.
Thank you for sharing that. For coming.
If you want to talk to me, I'm free.
Yeah. Anyone else wanna introduce themselves quickly?
Sure, I'll just really quickly, I'm Shannon Dufour Martinez. I am an executive board member for Vermont Home Care United. We represent the roughly 6,000 contracted workers working in the Medicaid paid programs, but working directly for families, not through agencies. And I would just second, it is the money and it's not just the money.
Yeah.
Anyone else wanting to introduce themselves?
Ellen Malone of Valley Services, and we serve people with intellectual and developmental disabilities.
I think so.
And Gloria Fed of Valley Services.
We see you all the time. I'm sorry, we see.
Hi, I'm Elizabeth Walters. I'm the executive director of Green Mountain Support Services. Thank you.
Thank you.
I would affirm everything that my good coworkers from Washington County shared. The crisis is real, the system is broken, and the needs are profound.
He's the one that had to go now. You want to ask a question?
Ask me, stay for a minute. I'll get to the other meeting a little bit later. That housing project that you, program that you talked about, that's one of 3 that are being developed because of a law that was passed here. And from those 3, we're going to try to figure out what is the best way to house the people that we're talking about. And we're not talking about institutions, we're talking about communities. So, thanks for bringing it up.
Thank you.
It took a long time to get that thing passed, to get the money in.
Yes.
But just to respond to what Eva said, that I appreciate what you said about, because being, that I'm a healthcare worker. I've known you a while. I was on on the school board with her mom years ago. That's how we met. So, many years ago now, over 10 years ago. Yeah, that was a rough time, but, and you were in school then, but yeah, but just I appreciate you sticking up for the healthcare workers, because as a healthcare worker, it really hurts that we do all this work. We have to fight for these raises, and then we can't even afford to use the healthcare. And so what you're saying about us needing help, it's true. Like when we have trauma, the agent, one place I work was offering me internally free treatment when I had trauma because I couldn't afford to go to someone for it. And then I was able to resolve it myself. But like the point is, like, that's why we lose people. It's because they get burned out.
And we go along.
Yeah, Captain's gotta go. I wanted to thank you
Yeah.
also because it is a reminder, we talk about turnover all the time in terms of fiscal. And we forget what that turnover
Yeah.
is, the trauma that is put on the people that we are there to serve.
Yeah.
So thank you, and thank you everyone for coming in.
Thank you very much.
Thanks.
Thank you very much.
Paul, where did you live in?